And welcome everyone. Good morning. Today we're going to be doing a chalk talk with Dr. Susan Block. We're going to be talking about her article called Our Unrealized Imperative, Integrating Mental Health Care into Hospice and Palliative Care, which I think is a much needed article and some very interesting subject to talk about. But first, I would like to introduce you. Dr. Block received her AB from Stanford University and her MD from Case Western Reserve University School of Medicine. She completed residencies in both internal medicine and psychiatry at Beth Israel Hospital in Boston. She's board certified in both fields. For more than 40 years, Dr. Block has been a national leader in the development of the field of palliative medicine, focused particularly on the psychological and psychiatric issues related to serious illness, and has led major innovative educational and quality improvement projects in a variety of areas. She's known internationally as an expert in medical education, communication, teaching, faculty development, and health system change. And she has contributed to research in medical education, palliative care, psycho-oncology, and health system change. During her career, she led multiple faculty development efforts, including the Project on Death in America Faculty Scholars Program and the Program in Palliative Care Education and Practice that trained many of the leaders of our field. She's got many, many more accolades, which are impressive to say the least. But on a personal note, she currently spends her time teaching undergraduates and clinicians in Vancouver, seeing a small number of patients, hanging out with family and friends, walking and throwing endless balls for her obsessed golden retriever, reading, learning Italian, and messing around with paints and printmaking. So welcome.
Thank you. I'm happy to be here.
So, I think there's so much to talk about this article, to be honest. I think starting on a personal level, obviously, in my case, I'm internal medicine trained, and I did a palliative care fellowship, and even I, feel undertrained in the mental health area field in my specialty. So I think this is something that it's worth talking about and kind of putting out there what are the things that we can do to change this. Um, Ideally, to begin with, I think, would you be able to share more about why you think there is such a disconnect between the integration of mental health disorders in the hospice and palliative medicine field?
Yeah, I'd be happy to. And I think in some ways it starts with stigma and the societal stigma against mental health disorders that extends into the culture of medicine and permeates it pretty extensively. Where psychiatry is marginalized, mental health is not seen as important in the culture of medicine, and people aren't taught about the impact of mental health issues on well-being and for physicians on the interaction between mental health and physical health. And I think that the culture of society, the culture of medicine, and then how that filters into training, because in internal medicine training programs, for example, there are no requirements for any training in mental health. In family medicine, they're very broad and general and kind of light touch requirements. And the overwhelming number of our practitioners in palliative medicine come from those two fields who have, relatively minimal training, if any, in mental health. And yet, so much of our clinical practice involves people dealing with serious illness who come in with mental health issues and who are dealing with the additional stress of a serious illness on mental health and have to kind of contend with that. I don't think we have a prepared work, teaching force because in palliative care, the majority of people, the overwhelming majority, only 1% of our palliative care faculty are trained in psychiatry. And while we have super social workers, they often don't have time to do the teaching and the training. They don't have the kind of special training that you get through medicine experience in, differentiating and understanding physical versus sort of psychological issues that are is really critical when someone has a serious illness. And so that we're really left with an untrained faculty who do the best they can without the training. And, I always say, like, would you really want a psychiatrist in the intensive care unit teaching you how to manage a ventilator dependent patient? No, but we kind of, in a way, you know, do that by having psychiatrists, by having internists and family medicine people without training, in palliative care, trying to teach about the mental health aspects of our field.
Yeah, and I think, as you say, I thought that that was the interesting part of this article because it puts out the problem. It explains many of the things that you're mentioning, for example, stigma, and then it kind of brings forth some potential solutions to the problem. And, speaking about stigma, which is, I think it's a big thing and a very important topic. Um, how, and I felt that you talked a little bit about that we are not good at discussing the the people stigma coming from the team and everything, but then also we're not good at discussing with the patients that we would recommend, for example, a psychiatric evaluation or a psychological evaluation. How do you see best an approach to talk with patients about this and not putting, judgment into that
Yeah.
conversation?
Yeah, I mean, I think that's one of the most important competencies that palliative care clinicians need to have. And I think it's very much in the framing of it. So for example, rather than saying, I mean, I don't think palliative care people do this very often, but it's all in your head, or we don't know what's going on here, so maybe it's psychological. I think we need to emphasize from the get-go that the mind and the body are connected. And the stress of a serious illness in palliative care has all kinds of psychological effects on anyone and everyone. And that our goal is to look at how those interact and to try to help you mobilize your physical resources, your psychological resources, your spiritual resources, your support system to help you cope with and live as well as you can with your illness. And so, in that context, to say, look, this is really stressful. This is really hard. I think you're doing absolutely the best you possibly can be doing. And it also might add another layer of kind of help and support for you to have somebody to talk to about some of these issues that you're struggling with. And I think that that's one way of saying it. But to normalize it, to depathologize it, to emphasize that this is an extraordinary circumstance. No one's ever been dying before, who we're taking care of. And so they're coping with a lot of very, very, very hard issues. So I think to frame it that way, I find really helpful. And, and also I think to frame it in terms of, there are many different ways of doing it. Look, I see you working so hard to put yourself through these, very rigorous treatments for your illness. We also have mental health treatments that can help you fight your cancer better or deal better with your heart disease. And we want to make sure you have access to all of these and not just the physical treatments because they all make a difference. So to frame it, more as a resource, as an opportunity, as I mean, we all know at some level the mind and the body are connected, but in medicine, it's kind of like, well, it's a mental illness or it's a physical illness. It's all a mush, I would say.
Yeah, that makes a lot of sense. And framing it that way sounds very, it really makes a difference. And I think patients tend to be more receptive when you frame it the right way and they feel more comfortable with, meeting with these people and so forth.
Yeah.
And, once the
Can
patient.
I say one more thing about that? Because I think it's really important and that we kind of neglect the issue. I think even we in palliative care, and maybe especially we in palliative care, because we pride ourselves on being such nice, accepting people, have more stigma against mental illness than we recognize and actually kind of work on. And that when we have a stigma about it and we're trying to make a referral, the patient picks that up. Okay. And so we are never going to be good referrers if we are carrying the same stigma the patient is having. And I just want to kind of emphasize that. And it really, I think that there are, um, this is a particular blind spot in palliative care. I think not because we don't kind of intellectually recognize it, but because psychologically it contradicts our self-image, our professional self-image as being, you know, open, accepting people. So something to be aware of and to work on for all of us.
It is very important. It has to start with us, right?
Yes, exactly.
That's
Exactly.
and as I say, as you mentioned this in the article, I mean, we know, but when you put it in numbers and you say 40 to 75% of the patients that we see are likely to have a mental health
Yeah,
disorder, that number is so big.
it's huge.
And right now, speaking of referral, going back a little bit more, what are the best tools to identify? What are our best resources to when we're doing an evaluation and consult of a patient? How do we identify all these mental health disorders in our patients? What tools can we get to help?
Yeah. Well, there certainly are tools for identifying things like depression and anxiety that are easy to use in practice and that we should be using. But I think the best tool we have is ourselves and training ourselves. And the challenge I see is that most palliative care clinicians don't have uh, a clear pattern recognition for mental health disorders. And we don't recognize what we're seeing when we see it. So in the clinical interview or clinical, interaction, um, you don't have to ask questions to assess hopelessness. You hear it, I mean, you can ask questions, obviously, but you hear many of these things. You hear hopelessness and helplessness and low self-worth and anxiety and, you know, um, uh, not demotivation. You hear so many of these things that just kind of come up in conversation, but we don't then put it into a framework and say, oh, hopelessness, helplessness, worthlessness, feelings of guilt. Oh, maybe that's depression. We think that it has to be, I don't, like a standardized test is a good thing, but we actually have a lot of that information. And if we ask good questions, um, I think asking patients directly how their mood is, asking people about, how they would assess, how would they evaluate their thinking processes? Do you think you're thinking as sharply as usual? We can ask people stuff like this and get very useful data because they know themselves. It's not always perfect. I mean, it's not perfect, but it gives us indicators. And I always, find myself, the question about, do you enjoy your daily life? Can you enjoy activities in your daily life? That's a really helpful question. And then I really listen hard for how people are looking at their future. And if we're having general palliative care conversations, we hear a lot about that. We hear how anxious they are. We hear how worried they are. We hear how much they're expecting negative things versus positive things. And that's all data. And part of it is us, you know, when we're listening to a patient, taking that in, learning to take that information and put it into a framework that helps us evaluate sort of for psychiatric disorders, mental health disorders.
Wow, I think that that's definitely very useful and a good tool to have in our, but as you say, there has to be bigger change, right? And there
Absolutely.
change has to come from up all the way down the ladder and everything. You talked a little bit about a collaborative care model.
Yeah.
How would that look, for example, in any patient setting? How would that look like?
Well, I think in at least in our setting, we kind of have that. I think it works better on the inpatient setting. I think the piece that most programs lack is a psychiatrist as a member of the inpatient palliative care team. And that is a huge gap. and as an ongoing part of the educational program of our fellows and our staff and our faculty. And because we have to recognize that with this high burden of mental illness that we have in our patients, and part of that, it's because our colleagues see us as good at dealing with these people, these psychiatrically challenging patients. And there's really interesting data about that. So they preferentially refer to us, but we don't have the training either. We have more of a proclivity, but we don't necessarily have the training. And so I think that having a psychiatrist as an integral part of the team is really critical. And I think a health psychologist, very, very helpful. So I think that having an expert mental health clinician on the team, in addition to the social worker who has usually his or her own area of expertise, but it's not a total overlap. There's shared shared functions and also different functions, I think is really helpful. And then talking doing team meetings where you talk about the patients and also around the mental health issues, since people don't have the background, integrate the clinical teaching with some conceptual teaching and some practical teaching about, well, this is how these are the tools that are available for assessing depression or anxiety, or these are the indicators that you might be looking for trauma, and going through some of these, and these are the thing. This is what a personality disorder is, and this is how it looks in practice, and this is what are the strategies that are helpful in managing them. So I think that we need specialists to help us with that. That's not easy stuff. And it's not just, anybody knows that. And so I think that's what is needed. And most places don't have that.
No, think, even our program really with lately started to integrate some some psychologists who are kind of listening in.
Mhm.
We've seen the benefit of having them with us and work with us. So I definitely agree that maybe adding more people to the team to include a psychiatrist would be so beneficial, and having them also understand the value that they bring to us and to
Exactly. And participate in the didactic training, and even in the ideal circumstance, um, observe clinician-patient interactions and provide focus, feedback, and mentoring you know, around complex conversations. Like, when I was earlier in my career, I used to go and see patients with the fellows. They would interview the fellows, and then we would go back and we would talk about the interview. And a lot of what I did was help them see how much they actually knew about the patient, but didn't know they know. They knew because they weren't putting it together, and help them think about how to respond when a patient is, very emotional, how to, what are strategies for calming them down. So it was really rich teaching. And I think that's the best, most efficient way, in a way, to develop some of these skills.
for sure. And it seems like not only fellows, but even us attending.
Faculty, yeah, absolutely. I totally agree. Yeah, yeah. Yeah, and it highlights another issue, which is that, I mean, the downside is only 1% of the people in our field are psychiatrists. The upside, though, is that we now have about 85 of those people in our field, and who are your palliative care trained psychiatrists, and they're an incredible resource. And trying to figure out a strategy for our field to support these people in training our faculty so they can help train the fellows and the residents and the medical students. We need a concerted faculty development strategy in our field to make sure that we all, everybody, no matter whether they're coming in from neurology or radiology or anesthesia or family medicine, that we all, have more of these capacities.
Course, I think that that would make a big difference. And speaking of fellows, do you propose maybe having psychiatry rotations added to the
Absolutely. Yeah, we have in our fellowship.
team?
And yeah, and I think it's really important. I don't think they're long enough, but I think the fellows value them, and there is really an opportunity to understand more about how mental health clinicians think, how they explore different issues, and to learn more about sort of the psychological, how do you enhance your capacity as a therapeutic agent for people with mental illness?
Exactly. And I think that would be so beneficial, to be honest. And it's something hopefully that we can start exploring even in our program. But one thing that you had mentioned and we were talking is that some mental health disorders are more understood by our team. Obviously, as you say,
Yeah.
depression, but then other ones are much less, like personality disorders or serious mental illness, trauma, and those things. Why do you think that's the case? And what can we do to overcome that?
I think those are really sort of generally serious psychiatric illnesses. And in general, we don't expect, um, ourselves or other colleagues to manage serious illnesses that are outside of their training. Okay, so this is where you need to have an expert mental health clinician involved. I think it doesn't necessarily mean that that's the only person who should see them, and indeed it should be a collaborative process. But and sometimes you don't have to see them. Like, you can do a lot of teaching and collaboration that helps people figure out how to how to do it themselves, like, with somebody with a personality disorder, which they're very hard to manage, very frustrating. And, even for psychiatrists, they're challenging. Okay. So I mean, the expectation that someone without that training is going to be able to manage them successfully is ridiculous. So I think it's having more access, bringing mental health clinicians in as consultants. One of the challenges there is I don't think many of them really are not comfortable working with our patient population and don't understand what the constraints are of working with people who are seriously ill and may not be as responsive as we would hope they would be. Because I think it's not a comfortable role for a lot of psychiatrists and other mental health clinicians to be involved with seriously ill patients. And so we find that's a huge barrier. And part of it is that's one of the things that the leadership in a palliative care program needs to do is to figure out who they can forge relationships with in psychiatry so that they can find people who they might, or their teams might be able to collaborate with.
So it
But it's
sounds
hard.
really sweet, right? Making psychiatrists and mental health clinicians more comfortable with our kind of seriously ill patient population.
Yeah. And
Awesome.
us being more comfortable with the psychiatry. It's a bilateral kind of engagement that we're talking about, which is exciting and fun. And that's the sort of sad part is that everybody's missing out on something that I think could be very meaningful to their practice. And I think one other thing I would say there is, one of the things that really struck me in a very informal poll that I did at the AAHPM meeting a couple of years ago was the number of people who, in one of those, quick polls that you do in a meeting, said that they not knowing how to manage people with psychiatric disorders was a major source of burnout and moral distress. And so I think that having more of this interaction not only is good for patients, but it's better for us because we're competency junkies. We like to be competent, and we're uncomfortable and unhappy when we're responsible for something we don't feel competent at. And that's what happens with a lot of these patients. And if we get more competent and have other people we can access who are more competent, we feel like we're actualizing our responsibilities in a more meaningful and professional way. So I think it's good for us too.
Yeah, definitely. And for us, for the team, and obviously, as you say, for patients, it's definitely going to make a difference, and thinking the people that are listening in and maybe trying to put their toes out there and start thinking, okay, what resources are out there
Yeah.
for all of us to kind of start digging and going into this and start reading more, learning more about it.
Yeah. Well, I think I think we don't have a good, easy peasy reference source, I have to say. I mean, there are a couple of books, textbooks about psychiatric aspects of palliative medicine. There was a terrific series on psychological considerations in palliative care. It was published in the Journal of Palliative Medicine. There are little places you can find, but we don't have uh, a full curriculum, I think, that addresses that. And I think that's a real need. I really think that's a need.
Sure. I swear I could ask 20,000 more questions, but I see that there's a couple of people having a couple of questions that I would love to address before letting you go, Dr. Block. So Marty is asking, can you talk more about the arrogance, ignorance paradox of
Oh,
palliative?
yeah. Yeah. Well, it's not unique to palliative care, first of all, but it's this phenomenon of not knowing what you don't know. And so it, I think, affects many different areas. I mean, I think when I started doing palliative care in an oncology hospital many, many years ago, um, uh, the oncologist said, "Well, why do we need palliative care? We already know how to do that." But and they thought they did, and they knew some things. But if you ask people now, looking back, did you really know? After seeing expert clinicians work, they would say now, and they do say now, we didn't really know what we didn't know. And that's the arrogance ignorance problem. And I think that it affects the issue for us. We're good people. We know how to be supportive to people. We care about people. So that's a lot, and it is, but it's sort of not expertise beyond, it's not the real expertise. So we think that's a substitute or as good as expertise, and yet you really need the knowledge. And I'm kind of amazed at, how frequently even things like delirium in my team, my great team, who I think the world of, is not recognized because or there or there's this feeling of, well, they seem okay, but you have to know that if you can seem okay and be profoundly delirious, okay, and so it's that kind of issue. There are many areas where it sort of sneaks in, and delirium is my pet peeve on that because I think it's a life-threatening emergency and we need to know about it. And when we miss it, I think it's a really serious mistake. So that's what I mean by arrogance ignorance paradox, and that's a good example of it.
I agree. And I think that that falls into the next question that Marty also asks. And he says, if you could suggest one or two topics that every palliative care clinician work on to improve their mental health skills over the next month, what should we focus on to make the biggest impact?
It's a good question. And it's through reading. See, there are things that you can learn in different ways. And so through reading, um, let's see.
Let me stall for you for a minute because
Okay.
they give you a moment to think about it. Because as I was reading your paper, I mean, so much of it was focused on changes that could be made at a big system level, bigger
Yeah.
level. And
Yeah. No, you're right.
the whole time I'm reading it, I'm thinking, but I gotta want to do it. I have
Yeah.
to want to do it. And
Right.
if I mean, there are topics that I have wanted to get better at over the last few years. Buprenorphine is a great example.
Hmm.
And I didn't have any system to help really teach me, but I poured my free time into just reading and reading
Yeah.
and reading about it and being
Yeah.
committed to it. And now I'm starting to use it a little bit. And I did have some expert help along the way. So I'm not discounting that
Yeah.
whatsoever. I
Yes.
think that was
Yeah.
valuable, but
Yeah.
I've got to put in the time and care enough about it. So I'm asking, if you've got a
Yeah.
topic or two, what should I pour my heart into that I can get better at on my own?
I think it would be really good to learn about defense mechanisms, which have to do with how do we cope with serious illness. and is probably not something that most people have ever learned about. Um, and I think that's a really key area. And I would look at um, I think the issue of countertransference
Mm.
is a really significant area. And the paper that I think lays it out the most clearly is quite dated, but I think it's really accessible. And in that sense, I think it's worth looking at. It's a paper from the New England Journal of Medicine in the late 1970s by James Groves, Groves. And it is very dated. And it's sort of appallingly dated in certain ways. But I think he does a really good job of laying some of these issues out. And then I would read another um, book called The Doctor, His Patient, and the Illness by Michael Ballant. Again, none of these are really these are sort of deep readings, not the kind of thing that, the 10 steps to being better at able to diagnose delirium. And I think that would be a good thing to read. But but these are deep readings that I think are ones that can affect how you think about every patient in your practice. And that's why I'm kind of turning to them. There are tons, I mean, you look up the key topics in a textbook, and, there's a lot in up to date in the Oxford Handbook and, everywhere you want to look, and you can get key issues. And part of that involves a self-assessment of what you think you're not so good at. That gets into the arrogance, ignorance thing because we may not see it clearly, which gets into countertransference, but at any rate, but those things I'm trusting people can find those answers themselves. I would go into the deep reading
Mm.
space on this myself.
Thank you.
Very you. And I think one of our fellows asked the same question about those resources. And the last question is coming from Kat McConnell, who is our health psychologist. She says, what is your recommendation and what collaboration between palliative providers and mental health providers should look like? Case consultation, warm handoffs, joint visits, etc.
All of the above. I mean, no, I'm really serious because, it depends. Our patients are so complicated and things change so much. And I think it's really hard to say that. There needs to be flexibility to meet what the patient needs and what the team needs. And I think that we have to remember in some way the mental health clinicians are also there to support the team, not by doing, psychotherapy, but by helping the team kind of address the complex needs of a family or a patient in the most kind of effective way. And sometimes a joint visit where there's a sort of bit of role modeling and a bit of bringing everybody together on the same page, presenting a united front. I mean, that's one thing. And sometimes that's what you need. In another time, you just need somebody to bounce something off. And so it's what I'm talking about is a pretty robust role that requires flexibility, and it can't quite be, subsumed into, I mean, it would be great to have somebody who came to case conference every week. That would be a great thing. But you're going to need other things too. So I would say flexible and, able and willing to do different stuff.
Wow, yeah, I that's definitely a good place to start, to be honest. And I think hopefully, this Chalk Talk is opening the door to further collaborations and more mental health, Chalk Talks and series and conversations. So we all really do appreciate you being with us this morning, Dr. Block,
Thank you. It was a very engaging and fun conversation. So thank you.
so much. And we hope that you have a great rest of your day and a great weekend.
And same to you.
Bye, folks.
Be well. Bye bye.